Dear students, welcome back. In the previous session, we have discussed about pain and the types of pain and also some of the theories which are related to the pain. In this session, we are going to discuss about pain gate mechanism. Before starting the discussion about the pain gate mechanism, how the pain is transmitted from the stimulus to the cortical region, that is called as pain pathway. So I want to discuss briefly about this pain pathway. Okay, how it happens. As we know that pain is usually considered to be a pathological state in itself by patients. Okay, and it is also an unpleasant stimulus. Okay, this pain is carried from the receptors. This pain is carried from the receptors by A delta and C fibers. Okay, and these nerve endings of this A delta and C fibers which receives this stimulus, and they will end into the first order neurons which actually present at the dorsal root ganglion. So from there these fibers pass in the region of dorsal horn. So where it ends, the first order neurons ends in the dorsal horn of the spinal cord. From the dorsal horn, the second order neurons starts, which is called as the tract fibers, There are many tracts, different types of tracts are present, but the two main tracts which carries pain to the next level is the spinothalamic tract. Okay, here you can find spinothalamic tract and spino-reticulothalamic tract. So here the second order neuron starts from the dorsal horn and it crosses in front of, just anterior to the central canal, and it moves to the lateral side of the same segment, and then that means it goes to the contralateral side, and then it ascends up the spinal cord, and then the brainstem, that is medulla pons and midbrain. Okay, and finally it ends into the thalamus. So these tracts end into the thalamus. From the thalamus, the third order neuron starts and it ends finally into the primary sensory cortex areas, that is 3, 1 and 2. So this is the pain pathways. So on this way from second order neuron to third order, it gives some collaterals given out from the pain pathway to the reticulate activating system, and also PAG, periaqueductal gray matter, and also mesencephalic reticular formation and the hypothalamus. So these are some of the collaterals given at this site. Okay, and pain is also related to components of the limbic system called as amygdala, so which are mainly responsible for emotional responses caused by pain sensation. So we are not worried about that one. So we are mainly worried about this the pain which is caused due to some pathology. Okay, yes. Normally at higher levels the pain is perceived at two levels. One is at the thalamus level and as well as the cortical levels. If subcortical perception occurs at the level of thalamus, which is mainly for crude pain. Here we can perceive the pain, but we cannot discriminate what kind of pain it is. For discrimination and for decision making, again, as the pain is taking place only at the cortical levels. So this is about the pain pathway. Okay, now we will move on to this pain gate mechanism now. Okay, yes. So as we have discussed about this, so at the receptor levels, when pain is getting, how the pain stimulus is formed means, for pain to be perceived, there is usually a chain whereby peripheral receptors are stimulated by noxious physical or chemical agent, and this stimulus is carried to the peripheral nerves, to the spinal cord, up to the cord through the brain stem, and so the cerebral cortex, where pain is appreciated at the conscious level. This route necessarily involves a number of synapses. Okay, here you have seen that many synapses are formed at different levels, isn't it? So, if you inhibit the impulses on their route to the cortex, is a mechanism where pain can be modulated. Okay, so the inhibition of impulses on their route to the cortex, if we inhibit the pain impulses not to travel to the higher level, that mechanism is called as pain modulation. Okay, yes. Nociceptive nerve endings may be stimulated by chemicals which are released by tissue injury and are accumulated as a result of metabolic activity, thus it creating an electrical potential at the receptor level. The degree of stimulation produced is governed by the amount of chemicals present up to a maximum point. And also it is postulated that a removal of these chemicals from the area may help to reduce the level of nociception stimulation. So this is the one thing. So what is that? If you reduce the chemicals which are formed at the area of injury, that thing also help to reduce the level of nociceptive stimulation. This is one thing. And thus the physiotherapeutic agents affecting the circulation may help achieve this. So for that reason only we are using ice and heat are often used in an attempt to reduce pain. The nociceptive stimulus is carried to the cord along either by slow conducting fibers or non-myelinated C fibers, or along fast myelinated A delta fibers. Both will eventually enter the cord via this posterior route. Okay, and it is postulated that as both of these fibers have maximum frequency at which they can conduct, or for C fibers it is 15 pulses per second. Okay, for A delta fibers it is 40 pulses per second. So that if a higher frequency of stimulation is applied, so that means higher stimulation of these two C and A delta fibers, okay, a physiological block to conduction might occur. So some agents can produce this required frequency and so may have this effect. For example, TENS, transcutaneous nerve stimulation, and interferential currents will have such a kind of high frequency which can block the pathway of these A delta fibers and C delta fibers at this level. That means we can block at this level. Okay, so this is about the pain gate mechanism. Okay, so and also there is other kind of mechanism which is present as there is another mechanism called descending pain pathway mechanism, which is also called as extra segmental mechanism. In this mechanism, the C fibers itself block by C fiber transmission. So we have seen that some of the collaterals are given to the midbrain, isn't it? So in the midbrain, we have seen that periaqueduct gray matter, that is PAG, and the raphe nucleus are present at this level. So these fibers, the collaterals which are coming from the midbrain, so they will have a separate pathway which are going to suppress, which are going to suppress the pain stimulus which are carried by the C fibers. Okay, so we have seen that these are the pain gate mechanisms. So first we will know what do you mean by pain gate. Okay, yes, you can see here what do you mean by pain gate here. So afferent input is predominantly via the posterior root of the spinal cord, and all afferent information must pass through synapses in the substantia gelatinosa and nucleus propriosus of the posterior horns or dorsal horn, isn't it? Yes. It is at this level that the pain gate, first postulated by Melzack and Wall in 1965. This theory suggests that for pain to pass through the gate, there must be unopposed passage for nociceptive information arriving at the synapses in the substantia gelatinosa. So the substantia gelatinosa and nucleus propriosus are present in the dorsal horns of the spinal cord. So this is the spinal cord, dorsal horn of the spinal cord. This is the level, and this one is the brain stem, and this is the cortical region. Okay, yes. So the fibers which are carrying are the small diameter fibers, okay, A delta, and this one is the large diameter fibers, that is a efferent fibers. So these are the C fibers, okay. So A delta and C fibers which are carrying, and these two end up in the substantia gelatinosa and nucleus propriosus of the spinal cord, okay. So if the gate is also concurrently receiving impulses produced by the stimulation of thermoreceptors and mechanoreceptors, then this traffic predominates with resultant presynaptic inhabitation of the small diameter nociceptive information. Okay, so these large diameter fibers also simultaneously receive this thermoreceptors, the stimulus which are received by thermoreceptors and mechanoreceptors at a time. So these form a synapse here. These form a synapse at the level of spinal cord. So this causes, which stops the traffic of this nociceptive impulses, and the impulses which are carried out by these mechanoreceptors and thermoreceptors or take over to the higher levels. So that means here the gate is closed for small diameter nociceptive fibers and open to this large fibers. Okay, yes. So many physiotherapeutic agents cause stimulation of endings connected to large diameter nerves and the use of manipulation, tense, interferential currents, heat, ice, massage, vibration and movement can produce a reduction of pain by closing the pain gate. Okay. So if nociceptive information is allowed through the gate, then the traffic will continue up the lateral spinothalamic tract, okay, of the spinal cord to the thalamus and from thalamus to the cerebral cortex. As this stimulus passes through the brainstem, so again it receives the stimulus and it passes, so descending cortical control. So from cerebral cortex it receives the pain impulses. So then what happened here? As the stimulus passes through the brainstem, it may cause an interaction between the periaqueductal area of grey matter and the raphe nucleus in the midbrain. These nuclei form the part of the descending pain suppression system. Okay. So, and the descending neurons can release an endogenous opiate substance into the substantia gelatinosa at the spinal cord level. So they are going to release a chemical called as opiate. Okay, so the chemical nature of this endogenous opiate, which may be beta endorphin, is such as to cause inhibition of transmission in the nociceptive circuit synapses. This is achieved by blocking the release of chemical transmitter called as substance P in the pain circuit. Okay, normally when the small diameter nociceptive ones ends in the substantia gelatinosa, where it releases the substance P which is carried to the higher levels, and then from the higher levels the response by the cerebral cortex is taken over by the descending pain suppression system. Okay, this one releases what is called as endorphins or enkephalins, which is going to reduce the formation of the substance P. That means it is blocking the release of chemical transmitter that is called substance P in the pain circuit. Okay, so consequently, if the physiotherapeutic agents are applied which cause stimuli to the flow along nociceptive fibers, this effect could be achieved. Okay, so if a cutaneous stimulus of noxious type is applied, such as ice, low tense, ultraviolet counter irritation, or renatonin ionization, transverse frictions, etc., then the release of enkephalins or beta endorphins could reduce pain at the spinal level. So pharmacological evidence supports this view, as when patients experiencing pain relief from TENS are given the anti-morphine agents, so their pain again returns. Therefore, it would appear that physiotherapists have a valuable role to play in the modulation of pain levels at peripheral at this level, spinal levels, okay, and also higher levels by the physical treatments they apply. Okay, so this is all about the pain gate mechanism. In the next session, we are going to discuss about TENS. Thank you.